everyone, and thanks for coming. I'm Grace Van Mel, and I'd like to welcome you tonight on behalf of MCIC, the Manitoba Council for International Cooperation. We're happy to be back with you for another Local Brews and Global Views discussion night. So as we begin, I want to acknowledge that I'm hosting this event from Winnipeg in Treaty 1 territory, which is the traditional territory of the Anishinaabe, Cree, Ojibwe, Dakota, and Dene peoples, and we're on the homeland of the Métis Nation. We're grateful for the chance to host this event, and thanks for joining. This event is sponsored in part by funding from Global Affairs Canada, and we're very grateful for their support. The event tonight is being held during Gender Equality Week, a time in Canada to celebrate achievements in advancing gender equality, even as we acknowledge the work that remains to be done. This year's theme is Advancing Gender Equality for All, and you're going to hear more tonight about the challenges facing girls in Nigeria and how improved access to sexual and reproductive health and rights services, sometimes called SRHR, and education is changing lives. So let me just introduce our speakers so we can hear more about this exciting project. We'll start first with Kacper. Kacper Nowacki is a program manager with Save the Children Canada. He's an experienced humanitarian and an international development professional, and he manages a portfolio of development and humanitarian projects focused on sub-Saharan Africa. Previously, Kacper also worked in programming to build resilient health systems and advance the right to health for marginalized people and underserved communities in Malawi and Canada, as well as humanitarian efforts in Nepal and Poland. So you've been very busy. We're also joined tonight by special guest, Mithila Deshpande, a gender equality advisor with Save the Children Canada. She's a gender equality technical advisor for the REACH project, the project you're going to hear about tonight, and supports Save the Children's portfolio of projects on sexual and reproductive health and rights, women's economic empowerment, girls' education, nutrition, and protection across development and humanitarian settings. So welcome, Kacper and Mithila, and I'll just turn it right over to you, Kacper.
Thank you very much, Grace. Thank you for the introduction, and thank you for inviting us to this event. We are very happy to be here, and for all the participants, thank you for taking the time and joining us for this presentation. Both Mithila and I, we work for Save the Children Canada. We are an international non-profit organization focusing on development and humanitarian aid. We work towards a world where every child has the right to survive, to be protected, to thrive. And we try to meet the needs by providing food and health services, but also improving their lives through more long-term means such as education and advocacy for gender equality. Save the Children Canada is a part of a global network of 29 national Save the Children charities, and we work to improve children's rights around the world in over 120 countries. We reach every year millions of children. In 2019, there was 38 million, 15 through our emergency responses that we delivered in over 50 countries, almost 27 through various health and nutrition projects, 8 through education programs, and over 3 through child protection services. And also in Canada, we have a national reconciliation program through which we work with local communities and child rights experts to improve Indigenous education, health outcomes. We distribute books and fund like culturally sensitive maternal, newborn, and child health clinics. Today, we wanted to present to you REACH, which is one of many programs we implement abroad. REACH stands for Reaching and Empowering Adolescents to Make Informed Choices for Their Health. This is a program we implement in Nigeria. And we'd like to talk about the context we work with, the challenges that we need to deal with, different approaches we have in order to meet these challenges, and results of the project that we implemented over the last couple of years, and different efforts different ways in which we try to make these results more sustainable. So to start, let me play a short message from Rahinato, our REACH project director, who, due to the time difference, unfortunately, she was unable to join us today.
Good evening, everyone, and thank you for being here. My name is Rahinatu Adamu Hussaini. I'm the project director of Reaching and Empowering Adolescents to Make Informed Choices for Their Health, a 3-year project that was funded by Global Affairs Canada. The project was implemented in 3 northern states in Nigeria. The states are Gombe, Zamfara, and Katsina. I hand you over to Kacper and Mithila, who are my colleagues and who will be telling you much more about the project. Thank you for listening and thank you for being here. Do have a good evening.
So let me first tell you a little bit about Nigeria itself. As a country, it houses the largest population in all of Africa. The capital of Nigeria is Abuja, and the nation is very rich in diversity, with over 200 different ethnic groups and over 500 distinct languages, although English is the official language. The 2 main religions in Nigeria are Islam and Christianity, with Muslims largely located in the north of the country, while Christians mostly found in the south of Nigeria. Now, there are 2 very important challenges that we have been facing when implementing our numerous projects in Nigeria, and that's not only the REACH project. First one is security. This project, REACH, has been faced with many different security incidents throughout the implementation period, and it continues to be challenged up until this day, especially in Zamfara and Katsina states, which are in the northern part of Nigeria. There are many reports of cattle rustlings, armed banditry, kidnappings. We actually had some very serious incidents of kidnappings in some of the communities where we serve. Some of these incidents, some of these kidnappings were aimed at children who study in schools, which obviously impacts. Oh, I'm so sorry. Impacts our programming significantly, and very often we need to proceed with extreme caution. Many of these, there are many different root causes. There's obviously climate change. There are some ethnic challenges where different ethnic groups sometimes turn to violence to solve different issues they face. So that's one of very key root causes of the challenging situation in Nigeria. The second one is COVID, which obviously affected our work across the world and affected all of our lives here in Canada as well. However, we see that in Nigeria, the COVID pandemic and different safety measures adopted by the government contributed to increasing gender equality gaps, especially around decision-making, mobility, and sexual and gender-based violence. So these are basically challenges that our project is supposed to address. Yet we were implementing it during a period that saw this pandemic that contributed to this situation, to these challenges. About the context where we implement, I also wanted to say that in Nigeria we see very high rates of child and early forced marriage. 18.5% of girls are married by age 15 and 49% are married by age 18. However, in northwestern Nigeria, where we focus our attention under the REACH project, this ratio is as high as 54%. This is the ratio of adolescents who are married before the age of 15. We also see a very high adolescent birth rates. It's 120 per 1,000 women aged 15 to 19. And in the northern region, this rate is also even higher. The maternal mortality ratio is also very high. It's 576 deaths per 100,000 live births. The pregnancy-related complications remain the main cause of deaths for women, for adolescent girls aged 15 to 19. Another factor is the high ratio of sexually transmitted infections, especially among adolescents, which is in the top 10 in the world. Now, one of the key acts introduced in Nigeria in 2003, Nigeria's Child Rights Act, has been the legislation passed in 2003, and the objective of this legislation was to actually challenge many of these issues I just mentioned. Unfortunately, it hasn't been fully adopted in the state level, and actually we'll talk about it later. REACH project, one of our objectives was to support local governments adopting this act. I think that right now I need to hand it over to Mithila to talk a little bit more about the barriers to adolescent sexual and reproductive health in Nigeria. Over to you, Mithila.
Thank you so much, Kacper. Hi, everybody, and great to be here and chatting with all of you. So let's look at some more details of the why, who, and how of this project, REACH project. Imagine yourself as a 14-year-old teenage girl in a remote village in northern Nigeria. She loves going to school, but is forced to drop out of the school by her father, who decided that she will marry a man who is several years older to her without her consent. She certainly didn't want to do that. Already at 15, she's pregnant with her first child. There are no health services that are immediately available to her where she's living. She always has to seek permission from her husband whenever she has to access healthcare. Now, this is the context in which we're working in northern Nigeria, specifically northwest Nigeria, where there is a predominance of a strong patriarchal structure. So there are very rigid gender roles and responsibilities for women and girls on one hand, and men and boys on the other hand. So this creates a kind of a power imbalance between them, leading to limited freedom for women, and especially adolescent girls, to make their own choices and decisions, particularly regarding when and how to seek medical care, as well as for their overall sexual and reproductive health and rights. Prior to the coming of REACH, the overall levels of knowledge of sexual and reproductive health, particularly among adolescent girls and boys in the region, was very low, especially when it came to the concept of rights. When we're talking about knowledge and rights of SRHR, we're referring to understanding of topics such as reproductive rights, sexually transmitted infections, maternal health and rights, access to contraception, gender-based violence, stigma around sex, sexual health, etc. There were also low rates of contraception use among adolescents. Contrast that with high rates of child early and forced marriage in the region, high rates of pregnancy among adolescents, and maternal mortality. Similarly, there was very limited availability of health services for adolescents. And then there was also the presence of gender-specific barriers in seeking medical care. For example, this was disproportionately affecting adolescent girls, such as seeking permission of their parents or male spouses when accessing medical care. Some girls in rural villages were forced to walk over 3 hours just to get to a hospital if needed. which entailed safety risks. And finally, most health facilities had limited capacity to deliver information about health, such that it was tailored to the unique needs of adolescents. Now, here's some background on the REACH project. It's a 3-year program which started in 2018 with the aim of improving the sexual and reproductive health of adolescent girls and boys, 10 to 19-year-olds, living in 3 Nigerian states in northwest Nigeria. You can see that on the map. It's Zamfara, Katsina, and Gombe. Now, the project targeted hard-to-reach communities, which had very high rates of child early and forced marriage, early childbearing, poor access to education, and discriminatory social and gender norms. The project was funded by Global Affairs Canada and implemented by Save the Children in cooperation with local non-governmental organizations, local partners who were directly implementing the project, as well as the state and federal government of Nigeria. Here are the key objectives of REACH. So these are basically 3 different pillars which we address. So firstly, improving access of sexual and reproductive services for adolescent girls and boys, such that they are delivered in a gender-sensitive, adolescent-friendly manner. Secondly, looking at decision-making, so increasing girls' capacity to make their own decisions about sexual and reproductive health. And thirdly, looking at the capacity of local youth-focused civil society groups, including women's rights organizations, to advocate for improved sexual reproductive practices in state policies and programs. So who did we work with? Now, our core focus was on working with adolescent girls and boys, 10 to 19-year-olds. SAVE takes a very nuanced approach in recognizing the specific needs and vulnerabilities of specific groups among adolescents. So here, you can see we worked with married as well as unmarried adolescents, married adolescent girls, their husbands, as well as other adults in the community. So parents, families, religious and traditional leaders in the communities, grandmothers, etc., as well as children parliament officials. Children parliaments are these, systems that are set up at the national level in Nigeria, for children to have a platform to engage and express themselves. Secondly, we worked with health workers in hospitals, in health centers, as well as private medicine vendors. And thirdly, we also worked with other important stakeholders, such as civil society organizations, government officials, and policymakers. So now let's look at the how. How did we implement this project? How did we do this? As you can see, this is what SAVE uses as a socio-ecological model. Essentially, what it is a holistic approach. It's a 4-tier approach, and in reference to adolescent sexual and reproductive health interventions, what it does is looking holistically at various levels of the society, because the groups that we're working with don't live in a vacuum. They live in their families, in a community, in a broader society. So therefore, we not only did this project work with the teenage girls and boys themselves, but also with their parents, communities, the health workers, and also the broader policy and legal environment, recognizing that without creating a change at each level, adolescents will not be able to claim their rights and take actions to improve their health. So this is just a representation of the 4 levels. And let's look at each level a little bit in detail. This is just a representation to give a sense of the approaches, and I will speak to some of the key approaches. So when we're looking at the first core circle, we're talking about the core group of adolescents. The project worked with adolescent girls and boys, and because we follow what is an age-segmented, nuanced approach, essentially, we tailored activities and interventions to differently to 10 to 14-year-olds on one hand and 15 to 19-year-olds on the other hand. So this was done in existing safe spaces or interactive spaces for groups of adolescents where they can meet and interact, important for them to learn and socialize together and take part in activities. For the 10 to 14-year-olds, there was different types of curricula on gender equality, on life skills, on realizing their aspirations and dreams, that was they were trained on and that they engaged in. And for the 15 to 19-year-olds, there was different kinds of training on sexual and reproductive health, sometimes also in collaboration with inviting husbands of married adolescents to these spaces. At the second level, in the second circle, we're looking at the parents, families, and communities. So what the project did was also, training parents, religious leaders, community leaders, grandmothers as important, community change agents and gender champions, because these are influential people who make a difference to the lives and choices and decision making of the girls and boys that we worked with. This was done by fostering dialogues and meetings to reflect together with the community members, using different kinds of approaches through videos, through testimonials of community members who had adopted some targeted behaviors, such as not marrying their daughters early or shared decision making, etc., as well as through displaying posters in communities, engaging community influencers in discussions and dialogues, etc. So this was at the second level. Now we'll look at the third level, or the third tier, which is the health systems. So again, at this level, when we're talking about the health infrastructure and the health system, we essentially targeted health workers, in healthcare centers and hospitals, as well as private medicine vendors and suppliers. And this was done through a suite of different kinds of training to them, on counseling adolescents, for the medicine providers to, knowing when to refer them to health facilities, talking to them in a friendly manner, respectfully. One of the key things that was done here was training on provider bias for health workers to provide equal and friendly services to adolescents, married as well as unmarried adolescents, just because it was noted in the beginning of the project that oftentimes they tended to have a bias in delivering sexual and reproductive health services, particularly to unmarried adolescents, not providing services if they did not have consent of male spouses or parents, being judgmental and not very friendly in their attitude. So all of this was addressed through these trainings. And finally, we'll look at the broader policy and legal environment, where the project also engaged with government officials through advocacy, through training, mentoring children's parliament on advocating for SRHR, adolescent sexual and reproductive health rights, etc. So this is just a broad snapshot of everything taken together and key approaches at each level and how we did this. And with this, over to you, Kacper.
Thank you very much, Mithila. So now, just really briefly, I wanted to talk to you about the results of this project, what we're able to achieve. Maybe I won't go through everything in detail, but in general, we have trained over 300 health workers on gender-sensitive and adolescent-friendly service delivery. We also trained over 1,500 safe spaces facilitators on our curriculums that they deliver to adolescents. And from these safe spaces, we had thousands of adolescents who graduated. We had almost 59,000 very young adolescents, 47,000 a little bit older unmarried adolescents, and 16,000 married adolescents who went through the training that we provided at the safe spaces at different age levels. We also, as Mithila mentioned, work with the medicine supplies vendors. We trained and sensitized over 200 of them to reduce the provider bias. Oh, and when we work with the adolescents, as Mithila mentioned, we also work with their partners, and that proved to be a very important component of our project, and it also turned out to be one of lessons learned. Maybe I'll talk about it in detail later, when we found ways to better engage, for example, with husbands of some of the girls that we work with, in order for them to understand some of the changes that were being discussed during the safe space activities. Now, here I also have a higher level snapshot of before and after the project. Now, please note that the now that we present here is actually a year and a half ago, when we conducted a study that showed the progress on various different indicators that we measure throughout the implementation. But the project continues until the end of August, so we expect to actually have a much higher results after we now measure all of these indicators again. But as you can see here, before the project, 54% of adolescent girls were married before the age of 15 in the communities where we implemented our project. After 2 years of implementation, that percentage dropped to 41%. 69% initially, 69% of unmarried adolescent girls felt confident on insisting on delaying marriage till the age 18. After the 2 years, this percentage increased to 85. And here again, very important was our work with the families and broader communities where these girls live, so they could also understand the benefits of delaying the marriage. That definitely helped the girls to do just that. Before the project in these communities where we implemented it, 51% of girls between 10 and 14 years old were aware of the importance of spacing the pregnancies. After the project, after the 2 years, it was 82%. Before the project, 47% of partners, male partners of girls, felt that they have a right to make their own sexual and reproductive health decisions. This increased to 54% after 2 years of implementation. 35% of couples reported shared decision-making about SRHR, increased to 64. And then when we talk about this health system level, where we also address various challenges, before the project, only 31% of health workers were trained on how to deliver gender-responsive, adolescent-friendly SRH services. Thanks to the implementation of this project, this percentage increased to 84%, and 0% of health facilities were delivering gender-responsive, adolescent-friendly SRH services, which increased to 77%. So, as I mentioned, we expect that these results will have improved even further during the last year of implementation. Now, the key challenge when we implement projects such as REACH is ensuring the sustainability of the results that we achieve. We don't want to see a situation where after we finish the implementation of all the activities, the situation goes back to where it was before we even entered these communities. So there are various ways in which we try to ensure that that we entrench the sustainability of project gains. In this case, we facilitate the adaptation of these gender equality approaches. So first of all, what we do is we work with the local service community organizations, local non-profit organizations that we partner with on various levels. Sometimes they provide technical support. Sometimes they support us through direct implementation in local communities where they have better understanding of the local context, and also the fact that people who work for these organizations and these organizations remain in these communities after we exit means that this capacity that we build stays there in a longer term, and very often these organizations continue to work utilizing funding that they can approach, that they can receive from other sources. We also work with local and federal governments. So as you could see, we work definitely with the federal government on the passing of certain legislation, but we then work with state officials in order for them to actually implement the legislation that was passed at the federal level, but also to build their support for SRHR. One clear indication of the progress we've made is we were measuring the state budgets that were devoted to SRHR, education and health, and continuously in all three states where we work, year after year, it has been increasing, and actually in 2 states, I believe, it actually increased from $0, and again, it continued increasing until this day. And we also work with community stakeholders, health workers, safe space facilitators, adolescents themselves, many of them who are engaged in the child parliaments. And through our training, through these years of the work that we spent together, we build true change agents who will stay in their communities and continue advocating for the rights of adolescent girls and boys, and will also ensure that these gains that we'll achieve will be entrenched. We also work to share the project success stories and lessons learned in Nigeria and abroad. So in Nigeria, we work with local media to talk about this project, talk about key challenges that it addressed, share success stories of specific adolescents who thanks to this project are now able to achieve the dreams and their life has truly changed. And we also share these stories here in Canada. We plan some additional ways to disseminate these success stories. We also mobilize high-level commitment for the community sustainability plans. So many of the local communities that we work with, they created these plans on how to ensure that, again, we can entrench the project gains. However, we also had to generate a state level and even federal level support, because this is where the budgets are approved. And the sustainability of these proposed plans depends on the available resources. So to solidify these gains, we organized a series of meetings at the state level and in Abuja, where we were able, I mean, not only us, because most of these meetings were actually led by these local communities, to secure certain funding pledges for example, for the next fiscal year and for the years to come, and like these specific components for which we secured funding, including safe spaces, ways to support the health systems, including some outreach services that we introduced to support more remote communities. Some states were also interested in scaling up this programming to other local districts in the states. And many actually of the government officials were themselves on personal level very much engaged in this work. Many of their children actually joined our safe spaces. Some of them donated funding or other resources to support this programming throughout the implementation period. And the final thing that we've done is about generating the understanding of the methodology. So throughout the implementation, people who we train, such as safe spaces facilitators or health workers, they gain a very good understanding of our curriculum, of the ways it should be implemented, and the overall objectives of the project. But we also created workshops for the officials from the Ministry of Education, other state level bodies, for them to have a full understanding of how these projects should work and how these projects can work moving forward. And these, again, these workshops were also organized with the representatives from local communities that were already engaged in these projects, to also create these personal connections, to network these people who we know are now interested in championing this kind of work further down the road. We have already seen cases where these local partners that we work with, or these community leaders that were engaged in this project, had different ways of actually engaging with the government, with the officials from Ministry of Education and other institutions, in order to discuss ways to move forward. So we wanted to end by presenting you with some voices from the adolescents and other people that we work with. Here is a short interview with an adolescent girl who was a part of the child parliaments.
Now that Reach project is over, I can now say it is a success, because it has been here for 3 years, and it has done a lot. It has impacted and touched a lot of lives of parents and children, and even those close to them, because I think I want to give a story of what these children have said. Some of them have now said before Reach project, they don't used to help their sisters, they don't used to do house chores, the boys among them, but now they help their female siblings do house chores and a lot of things. And another thing they have told me was, now girls are allowed to go to school, because even the parents and the religious and traditional leaders are enlightened about the importance of that girl education. So they allow them to now freely go to school. They have also said they will, in the future, go for all those antenatal care and a lot of medical things like hospital delivery and so on, because they are informed about its importance.
And here's a short interview with one of the health workers who was also volunteering at one of the safe spaces in Zamfara.
Our younger adolescents don't usually come to the hospital for family planning services because they are ashamed of coming to the hospital. Like the unmarried adolescent, they don't used to come to the hospital. Maybe they are ashamed for someone to see them. But in the process of this coming of Save the Children to this our town, Sagiru, they are aware and they are not now shy of coming to the hospital. They will come and give us all their problems. They will explain, and we are going to give them all the special attention and assistance that they want. We used to give them health talk on how to take care of themselves, how to come to the hospital for delivery, how to take care of their babies, how to take good nutrition when they are pregnancy and after they have delivered.
We also have a few more testimonies. Maybe I'll just read one of them. I also want to give some time for questions. So after attending a safe space for a month, Hawau wanted to enroll back in school. She felt she made a mistake when she stopped her education, and she now understands that with education she'll have a better understanding of her own and her family's health. To my surprise, my husband talked to a facilitator about the possibility of me going back to school and obtaining my secondary certificate. This was after discussion she had with her husband after one of the Safe Spaces SRHR modules they have attended together. So I think I can stop here. We have a few more testimonies, but I wanted to see if there are any questions.
I'll start with a question just to give people time to put some in. I was really struck how this program isn't just about access to health services. It really seemed to focus on the decision-making power among youth, especially girls. I mean, even that statistic you had up on the screen, there's a significant jump in the number of people who really felt that they had a lot of, they were more empowered to make those decisions. And so I'm just wondering, if you or Mithila could share why it was important to Save the Children to address these sort of gendered power imbalances in this way.
Sure. Thanks so much, Grace. I'll take that question. And such an apt question as we're in Gender Equality Week. So for us as Save the Children, gender equality is a basic right. It's at the core of all the work that we do. So when we're working with girls and boys, it's really, our three breakthroughs that, survive and learn and protect. That's, the core of our work on child rights. When we're doing that, we look at it in a holistic approach, as I had mentioned, particularly in the case of this project. Girls and boys don't live in a vacuum. They don't live in isolation from other members of the society and their families, their communities. So we feel it's important to work with all of them especially as adolescents. Basically they're transitioning from childhood to adolescence to adulthood. They are learning norms, they're internalizing norms, they're normalizing them. And so some harmful gender norms, discriminatory norms are at the root cause of these inequalities. So which is why we think it's so important to look at power imbalances, decision making, access to information, not just for health but also in other parts of their lives, in their relationships, taken together, because without that, just looking at the access side of the equation, working with health workers or the government is not enough if we want girls to have the agency to make decisions, and regarding their rights and choices.
Thank you so much. We did have one question come in here. This person just wants to know how well you think this model would transfer to other areas and countries.
So maybe I can answer that. Maybe Mithila, you can add a bit more. So actually, this model has already been implemented in other areas and countries. So the basis of our curriculum, we call it Choices, Voices, and Promises. So this curriculum was developed initially and first introduced by Save the Children in Nepal, but then it was implemented in various other countries. I know that there was also Bolivia, now Nigeria. Every time, obviously, this curriculum is adapted to the local context, but the basis where we see this like three-pronged approach, where we work with young adolescents, we work with older adolescents, but we also work with communities, remains the same. And there are certain approaches that Save the Children introduces globally, not only this one, but we have many more, where we like hone them across different countries and improve across throughout the years of implementation. So even after this project, we spent the last 2 years implementing, in our view, a very successful project, but we also learn a little bit about this tool, this curriculum that we have, and now we're able to improve it even further and continue implementing it in other locations, other countries where we see that there is a need for this kind of approach.
Sounds like some really great learning. It might be great to have that sort of scope to be able to transfer from country to country and what you've learned. Someone else has a question here. They said you mentioned the pandemic, and that would have interrupted the project. They're wondering if you could comment on how you handled the challenges of the pandemic in this program.
I can also answer this. It was a difficult year, I think, but I think we the project and the communities that we work with and adolescents proved to be very resilient. So immediately as the pandemic was unfolding, we had a few studies that we did in order to better understand how the pandemic, how the lockdown that also was instituted in Nigeria affects the adolescents, but also their families and the communities at large, and how can we respond. There were many activities that we had to adapt. We were able to find some funding for face masks, hand sanitizers. At that time, we also were disinfecting schools actually to help local communities to have more confidence actually that going back to school when they finally reopen was safe. We also introduced not only under this project, but in Nigeria in general, in other countries where we work, various COVID protocols. We had to decrease the number of adolescents, for example, who can take part in a meeting. We took most of our meetings outdoors. There are many various ways in which we adapted, not under this one, but for example, many other projects that focuses more on education. We introduce remote education through radio. So we're purchasing radios, distributing them, organizing learning circles in communities, and then delivering some educational content remotely.
Just to add to what Kacper was saying, a number of different studies that we did also included a gender assessment, as we all know that, the COVID pandemic is also, hand in hand with the invisible pandemic for women and girls all over the world, whether it is about sexual and gender-based violence, girls having to drop out of schools, childcare, care burdens, and so many other issues. So, with the onset of the crisis, the COVID crisis, we also did a rapid gender assessment in the project areas. And based on those findings, we tried to adapt our project activities and implementation on, providing more trainings to health workers, just adding those in our communications and outreach, and ensuring that we were supporting the girls and boys and the families that we work with in this pandemic. Thanks.
Certainly a lot of work went into this project. There's another question here. This person's just wondering, did you face any problems with misinformation when you were rolling out this program? They don't specify what kind, but yeah.
Yeah, I was just going to ask what kind of misinformation. There was definitely misinformation around COVID, and that's what our initial assessment showed quite clearly, that especially at the beginning of the pandemic, many of the adolescents that we work with didn't really believe it's real, and there were some conspiracy theories about the root causes of the pandemic, but we actually included education about COVID into the curriculum. So we were, like every meeting with the adolescents, but also, let's say, with the government officials, right, or with the health workers, was about the importance of COVID, response and different precautions measures. But also we trained our health workers, the ones that we would normally mainly train, or SRHR, also on how to how to prevent COVID from spreading, but also how to recognize if someone might be sick and what to do in that case.
I have two more questions here. This first one is about security risks. They're curious if there were any security risks in the project locations and how you worked with them, around them.
Can I answer this one as well, Mithila? Sorry, next one will be for you, I promise. So there were numerous security risks that we had to work with. There are various root causes of security risks in Nigeria. In Katsina and Zamfara, for example, very a contributing factor are clashes between herders and farmers, which can be directly linked to climate change, as the Sahara Desert is moving further and further south, and the nomadic animal herders enter into like violent disputes with Nigeria, and has been ongoing for many years. The impact of COVID also increased some economical challenges, poverty, which led to increased cases of banditry or establishing illegal checkpoints that collected fees and sometimes rob passengers. There is also an issue of the uprising, the insurgency, which is more apparent in the northeastern Nigeria, but there are also situations in northwestern Nigeria where they target schools and they target children in order to disturb their education. Some of them are motivated by like ideology. In some cases, it's just for ransom, and we have seen cases of children being kidnapped from their schools and later being released after the government negotiated with the kidnappers. Obviously, all of that impacts the families, impacts the children, and impacts like the entire communities. And I'm sorry, and the last thing, and how did we deal with that? So obviously we have different security measures, and I think the key thing is that we work in the communities. So we very often know in advance if something is happening, and we have ways for us to hibernate our projects to make sure that nobody is at risk. That for example, if we know that a certain school or a certain location might be a target of a banditry attack, we put our implementation on hold, ask children not to come that day. So that would be basically it. And then also we work very closely with the local government. That is also very helpful.
This last question is, this person would like to know if encouraging people, especially parents or older people, to be a part of the program, was it difficult to encourage people, if they're older or parents, to be a part of the program?
Yeah, so I think the project definitely came with its challenges, but the important part here was our approach, which was, working through the religious and traditional community leaders who are such a trusted, respected part of the community. So working in culturally appropriate and sensitive ways, training them, who would then talk to others in the community, encourage them, also in their religious places of worship, and talk to older parents in the community. There were also some challenges with engaging husbands of married adolescent girls, in the training sessions. But again, we all worked through community leaders, religious leaders, as well as, through other, gender champions or change agents who would, encourage them to participate, or just demonstrating their behaviors was an inspiration for others to either, be a part of the activities or learn from that, especially on, seeing changes among the, children as well, on, sharing of household tasks, joint decision making, shifting of those norms, which was all kind of, made it possible to move the needle a little bit.
That's great. Thank you. I really am struck by some of the serious results you had with this program. Thanks so much for sharing about it. And thank you everyone for those excellent questions. And I just want to say thank you so much. It was really great to hear from you and hear about this program. And thanks everyone for attending. Thank you again.